The dorsal fetus artery was well felt, and at this moment, even the sepsis was ruled out, and the chest X-ray was demonstrated the evidence of the over pulmonary circulation. Next slide, please.
Sir, can you speak a little louder, sir?
Oh, yeah.
Okay, sir.
And you can see on the X-ray there is a cardiomegaly, and also there is increased circulation into the lung. It's like a pulmonary edema. This is what exactly this baby had. Next slide, please, Prashanth. And this is what exactly I like to the audience to, especially the juniors, to understand what are the important clinical signs you need to see on clinical rounds. Even you see a sick baby every day, make sure that if there is any fluctuation in the heart rate, suddenly the heart rate was normal, suddenly started to increase, and then this 97, what I have shown you, is at 100%. Suddenly the baby started to have more requirement of the FiO2, and you see that this precordium is very active, and you auscultate on the chest, you see that there's a murmur, systolic murmur, and you feel the dorsal fetus artery is very, very well fed. And on the monitor, you see there is a big drop in the diastolic blood pressure. And as I told you that the endotracheal tube has got blood in it, and at the same time, the blood gas demonstrates what is called as the metabolic acidosis. So what I'm talking about is, in addition to that, look at gestational age and chronological age. This is very, very important. What I put on either side, these are the pillars. The reason why I put gestational age, we are very lucky to have babies more than 28. If you look at our clinical admissions, very, very rarely we see babies born at 24, 25 weeks. Most of the babies, what we see is after 27, 28 weeks. Because all data, they say that lesser gestation, especially less than 20 weeks of gestation, if you look at the closure of ductus, takes a long time. Sometimes it may close, or it may need some intervention to close. Similarly, you need to look at the chronological age of the baby. What is chronological age? If the baby is born, first initial phase, first 3 days. Am I audible, Prashanth? Am I audible?
The voice is not clear. That's what I'm getting a lot of chat messages, sir. I can hear, but just speak a little louder and little slower, sir.
Okay. The chronological age, if you look into that, here the baby is on day 3 of life, baby develops intraventricular hemorrhage. And if you look at as the baby's day progress, you find there is actually a chronic lung disease. And this is how the chronology, even chronology is also important when you have a case of the significant ductus arteriosus. So give importance to the clinical signs, and then you look at whether you have a significant ductus arteriosus and whether it is getting augmented using the echocardiography. Next slide, please, Prashanth. This is what we see, the paradigm shift. If you look at before 1970s, the people, the clinician used to stand in front of the baby and then look at all the clinical signs. And there is a big shift between 1970 and 98. You'll find there is the entry of the echocardiography. Even with the echocardiography, there was nothing luxury in it. Only the MO demonstration was there. And people used to say that, oh, clinically, baby is looking, having significant ductus arteriosus. In addition to that, this baby has got left atrial enlargement on it. This is a significant PDA. But subsequently, you'll find the color Doppler, 2D echo, they started getting entered into the technology that made the clinician taking a lot of signs, evolving a lot of echo signs in addition to the clinical signs, thinking that clinical signs not enough or not sensitive to diagnose HFPDA. And if you see the 80s and 90s, that is the time actually the neonatologist, he started to do on his own and started to develop what is called as the functional echocardiography in the diagnosis of HFPDA. This is very important. Even when the neonatologist, he does this on his own, make sure that there is no structural problems associated with the baby. That is very important. Once the structural heart disease is ruled out, the functional aspect can be clearly done every day on everyday basis, clearly by the treating neonatologist. This is the paradigm. Start with just history, just clinical science, and then the technology as the day progressed. Next slide, please, Prashant. Yeah. This is what exactly we look at. Once we know that the technology has come in, we look at ductus arteriosus. Always remember that though we are looking at a small link between the pulmonary artery and the aorta, it's a small link, but think broad. Why do I say think broad? We know that it is only ductus arteriosus, which was present in the fetus. Now it is also present in the neonatal period. And when you think of hemodynamics as a part of this, the ductus arteriosus, three things always you should remember. Don't blindly look at the ductus, oh, I have a ductus and I'll treat it. No. With the clinical acumen, rule out structural heart disease. Most of the cases, they mimic actually structural heart disease. First thing you should say that you have to do what is called segmental approach of the heart. Look at the anatomy of the heart, rule out structural heart disease. The second part, always assess the ventricular function because they are like a room in a house. So you need to see that rooms are, framed properly or not, whether the rooms are functioning well or not. Make sure that ventricles, the walls are really strong or not. If the walls are not strong, nothing is actually going to move because you have what is called as systemic hyperperfusion. And in the same way, when the management comes into picture, we need to look at whether the significant ductus arteriosus has got any evidence of lung pressure. If you have a big lung pressure, increased lung pressure and ductus arteriosus, you cannot treat with the medications, so many medications what you have in your acumen. So you cannot do that. So in the nutshell, think broad, just don't look at the link and start treating. Next slide, please, Prashant. Yeah. So once you know that structural heart disease is ruled out, you are looked into other characteristics of the heart. Look at three important things. So I'll finish only with these three things. One is the ductal character, very important. Second part is the only two things remember when you have a ductus arteriosus. Whether this ductus is causing systemic hypoperfusion, that's one part. Second part, whether it is causing pulmonary overcirculation. If you look into these three characteristics, then with the clinical acumen, you can come to a conclusion that whether this baby really requires any treatment or not. Next slide, please. This is what exactly, okay, it's not, okay, the video is not, anyway. First thing actually you need to look at, as I told you, the characteristics of ductus. First and foremost thing, does this baby have ductus arteriosus? You have to remember this is a 2D and you got one, on the left side you got 2D image, on the right side you got the color image. The 2D image you see that there are three, if you look at this is the aorta, then you have got pulmonary artery. Pulmonary artery has got three branches. It's not exactly two branches you can see. What it is called as, this is the aorta. You can show aorta, Prashant. Aorta in the center, that is the pulmonary artery. And then what you see adjacent to the aorta is the right pulmonary artery. Adjacent to the aorta, that is the aorta. Adjacent to the aorta, on the right side, here, this side, down. This is the right pulmonary artery. Next to right pulmonary artery is the left pulmonary artery. Then you have got ductus arteriosus next to that. So you get, this is called as three-leg spine. Similarly, if you can see on the color Doppler, you've got two blue jets, that is right pulmonary artery and left pulmonary artery. And you can see the adjacent, the red jet, that is the ductus arteriosus. So you need to, this is very important because the question comes here, when you have a ductus, you need to know whether this is a blue jet or red jet. Most of the times actually you see the red jet. Sometimes you may get the blue jet also, especially when you are dealing with a pulmonary hypertension, structural heart disease, what we call it as right to left shunt. So looking at the ductus, you can know that am I dealing with the right to left shunt or left to right shunt, and this is how the ductus. So you confirm that there is a ductus. Then after that, you need to measure. The measurement comes actually, next slide please. Yeah, when you have a ductus, if you see, this is called ductal U, where if you see the probe, this is called as the footprint probe. It is placed in second intercostal space on the left parasternal area with a marker facing to the left. You can open what is called as big vessel view. If you see here, this is I have mentioned there, root of aorta, I have showed actually right pulmonary artery, left pulmonary artery, and patent ductus arteriosus. Three legs I have seen there, leg 1, leg 2, leg 3. This is the characteristic feature. This ductus PDA has got two components. One component, what I have shown that actually I have measured it. Measurement is around 2.6. You can see that, yeah, millimeter. That is this one. This is the pulmonary end of ductus arteriosus. The other end below, where I put my HAV, that is actually the aortic end. The measurement should always be done at the pulmonary end. That is the narrowest part of the ductus arteriosus. That measurement is very important. Remember, when you have a big duct, use only the 2D echo. Don't use the color. If I use a color in a big, that sometimes overestimates. Suppose the 2.4 looks like a 3 millimeter. So remember that if the ductus is very prominent, 2D echo is enough actually to detect. Sometimes there is a problem actually because anatomical configurations may not get the best view to measure the length of the ductus arteriosus is your suprasternal view. I have shown that suprasternal view here. The probe is placed in the suprasternal space with just the marker facing to the jaw. And when you see that, you can open the ductus. I have shown the ductal view here. This is the arch of aorta. You've got right pulmonary artery, RPA. Then next to that is the LPA. Then you can see the descending aorta. There's a connecting link between the descending aorta and pulmonary artery. That is the ductus. And if you look at, I have compared this, the same baby, I have compared the 2.46 here on the short axis view, and here the suprasternal view, I got to almost the same 2.48 millimeter. This view is important. Everyone should remember, when I have a ductus, always do suprasternal view. Most of the times, actually, you may get coarctation of aorta, arch of interstitial aortic arch, and then hypoplastic left heart syndrome. So if I want to look at the morphology of the arch of aorta and the other components, you should look at suprasternal view. If you don't look at suprasternal view, when there is a PDA, there is a big mistake. Be careful. Next, so when next question comes, what is the size and does the size matter? It's very important. People just say that, oh, big PDA means, yes, you need to think of that there's a big PDA, 4 millimeter, oh, short medication. It's not. What is the shunt gradient between the two circulations? You've got two circulations, the pulmonary circulation and the aortic circulation, the systemic circulation. What is the shunt gradient? So with that, you need to calculate. It is not the number. Number doesn't matter in the rectus arteriosus. It is the pressure gradient. Now, people, they look at, once I know there is a ductus, I should know what's the direction of the flow. Is it flowing right? So what is right, left? I think there are some beginners or some audience too where just they want to know what is this right to left. For them, because of time also, it's just simple word to use. Always remember that whenever there is a circulation happens from the pulmonary artery to the aorta, you call it as right to left shunt. That means pulmonary circulation to aortic circulation. What is left to right? Left to right is the circulation happens from aorta to the pulmonary artery. More circulation happens. That is called as left to right. When the both circulations pressure the same, then you get what is called as bidirectional shunt. This is a simple word. What is right to left shunt? What is left to right shunt? And bidirectional shunt. Next slide, please, Prashanth. Yeah, this is another important. People, they thought, okay, we looked at the diameter, and Venkatesh said, actually, oh, just looking at the diameter is of no use. And the people thought, okay, as a clinician, I keep doing the ultrasound every day in a sick neonate, having the clinical acumen, and look at this pattern. So there are 5 important patterns you should see. So it's very easy to do. The probe is placed again in the second intercostal space, left paroxysmal area, with a marker facing to the left. You keep doing. As soon as the baby is born, most of the times actually you get the wave, only the wave you find below the basal line. I'll show you. This is the basal line. You can show Prashanth. Basal line is the one here, and below that is the right to left shunt. Above that is the left to right shunt. I have not seen in my experience having only this. If you see some of the literature, they have shown that the first step you see is only the complete right to left hand, which are not. Even though I have seen the babies immediately after birth, I'll see on this pattern. That's the reason I put here. This is called as bidirectional shunt. Means what? You will find the flow is happening equally both on the pulmonary side and aortic side. What you see above is called left to right shunt. What you see lower down is your pulmonary part. What you see above is the aortic part. That's what left to right shunt above and right to left shunt below. So now this is called as Pphn type of PD. So this I'm not going to touch the baby. Next day I'll come. Then I look into that. Another thing. This is called growing phase. So you see what is happening in growing phase. And if you see the Pphn type and this the portion which is above the basal line, it is increasing, correct? The one which is below the basal line, it is decreasing. So that means the pulmonary pressure part is going away. I am getting more of left to right shunt. So then it is called growing. If you see this portion has got two components. The systolic component, the peak here you can see the growing phase, Prashanth. Yeah, the topmost is the systolic and the lower down is the diastolic. See that one? Then what happens? And it is like this. Children, they start growing, then they start dancing. Similarly, PD also same. Once it starts growing, it starts dancing. What does it do? If you look into that, the systolic peak is there, pulsatile variety where you will not find anything below the basal. Do you see anything? What is the difference between the Pphn type one? The one which is present below the line, basal line, it is not there. There is no right to left shunt. You've got purely the left to right shunt. And the distance between the systolic and diastolic, it is getting widened. What do you mean by, in other words, you must have heard restrictive type of PDA and non-restrictive type of PDA. What is non-restrictive type of PDA? If I look at the diastolic flow in the pulsatile variety, the diastolic flow, if it is less than 50% of the systolic point of that, is called non-restrictive PDA. If the diastolic flow is more than 50% of the systolic, is called as restrictive type of PDA. So what I am telling you people is, if you have a baby with a growing phase and pulsatile phase, be careful. Okay, sometimes if the baby is physically also not doing well, if you are seeing this, then whether there's a need for managing this baby or not. If you look at the closing PDA, what happens? The pressure increases, correct? Because it is closing. That's why I said the size doesn't matter. What I'm seeing here, I'm not seeing anything. The one which is below the line, the basal, I'm not seeing anything. But what I'm seeing is both systole and diastole have started to increase. They are about 2 meters per second. But there, what's happening? It is called as closing PDA. Oh, yeah, it is going. I'll treat. No, don't treat. Nature is treating. So it is closing PDA. If you see something, both systole and diastole is going, don't worry. If the systole and diastole are going in a different way, diastole is going down, systole is going up, that is the point you need to look at. I need to treat this baby. But nature is so great. Most of the times, actually, we clinicians, we intervene and treat. Nature, we don't leave the nature to treat. But exactly what happens after some time, if the baby is suddenly you see baby is doing well, everything is fine, then it may get closed also on its own or with medication. In the closed variety, you will not find anything on the line. That is, above the line, you don't see anything. What you see closed variety is only you get pulmonary flow. This is called closed type. My friends, please, if you have luxury, or even whenever a cardiologist comes and sees, make sure that you point there whether I'm dealing with a case pulsatile and growing type. These are two important where non-PDA. Keep looking at, but never forget to see the central point, the baby. Don't give just importance to these values. Next, this is again given by C et al. Now, once I know that there is a ductus, the size doesn't matter much, the flow matters sometimes. The next important thing is we need to look at, I'm going to look at two important things when I do echo in a small baby, the ductus arteriosus. One is the volume loading, the second is pressure loading. What is this volume loading? So I told you in 1970s, after that, when echo machines came into picture, only the MO was there. This has got historical. That is the reason people, they don't want to leave this LAO ratio. You ask, what is LAO? First you ask, PD is there. Oh, what is LAO ratio? But important thing you should know is LAO ratio is what? It is a left atrial enlargement because too much shunting has happened. It has to come into the left atrium, then it has come to left ventricle. Left atrium starts to enlarge. That is what is called left atrium starts to increase. Then when you put a probe here, this is called parasternal long axis, where the probe is kept in the second intercostal space, left parasternal, with the marker facing to the right shoulder joint, you get a view like this. When you get a view like this, you put a M mode and you cut at the anterior mitral leaflet, you get the M mode wave. You see the aorta and you see the left atrium. Aorta you measure at the end of the diastole and you measure the left atrium at the end of the systole. So you'll find the bigger diameter has to be measured in the left atrium. Now, remember, somebody asked you that is there anything you see small LA with significant PDA? Yes, remember that if the baby has got big ASD, you may find all blood is entering into the right, you may not get left atrium enlargement. And also sometimes if you start looking only at the left atrium, if the mitral valve is not functioning, then what will happen? The left atrium starts to increase in size. So left atrium enlargement is only an entity you to see and find out what is the cause for that. But it doesn't tell you that, oh, there is significant ductus arteriosus. People now, they look at, instead of LAO ratio, let us see only the LA diameter. So that's why somebody can do some study on measuring the LAO ratio and left atrium in the assessment of the ductus arteriosus. So this is what exactly I showed you. If you see the LAO ratio, it is around 1. It is a normal baby. And in a significant PDA, if you look at the left atrium, is enlarged on the right side and it is about 2.42 centimeters. And this is called as, and anything more than 1.4 to 1.5 centimeter LAO ratio is, as per historical tradition, if you have proper PDA, no structural heart disease, you consider this is significant. So another thing always they look at is what is called as the left ventricle diastolic dimension. So if again you cut the parasternal long axis, you cut at the mitral valve, you get M mode. You see that the left ventricular volume, because the blood is coming too much into the left atrium and going to the left ventricle, in diastole, you look at too much blood in the left ventricle. So look at left ventricular and diastolic volume. That also will give you a clue, and that is important. So left. So my friends, if I want to see on echo in PDA, remember that this flash view may give some evidence in a significant PDA with no structural heart disease. Next slide, please. Yeah. Then another important thing is left ventricular output. So we all know that left ventricular output is an important. The normal left ventricular output is 150 to 200 ml per kilo per minute. Anything exceeding 300 ml per kilo per minute, we call it a significant PDA in the evidence of no structural heart disease. But we had a baby recently. Left ventricular, the output was around 100 ml per kilo per minute, and this baby had significant PDA both clinically and echo-wise. How do you explain? That is the reason don't give value for this, because there the myocardium was not in a position to pump blood properly. So there was an intrinsic problem because of ductus arteriosus. That's why the reason is, if the myocardium is tired too much, it cannot pump the blood. When it cannot pump the blood, how can you expect this left ventricular output measurement? Another problem here is left ventricular output. It is always confounded by your ductus arteriosus also. That is the reason very difficult to assess, but you should consider every day when you do whether it is increased. Suddenly, if you see 200 ml per kilo, 300 ml per kilo, 400 ml per kilo, then you see other things, then you may consider. How do we do that? So remember, for the measurement of left ventricular output, two views you have taken. One is called parasternal long axis. You can see here on the left side, with a marker, the same place to keep the probe in the second intercostal space in the left side. The marker facing to the right shoulder joint, you get what is called as you cut the MO, you can measure the aorta. Can you see that aorta measurement I have put here? AO diameter. This is relatively static. That's the reason they consider this AO diameter. The second thing is you take the four. You see this probe on the right side. I have placed in the apical area with the marker facing to the left. I have tilted little bit up to open the 5-chamber view. When I open the 5-chamber view, left ventricle is open into the aorta. I kept the probe. You can see here, pulsar Doppler is kept here at junction of left ventricle and the flow. You get what is called as velocity time integral. That means if I want to measure left ventricle output, it is not just the diameter. You need to take the flow also. That is the reason they use the formula for you can see that the diameter pi square divided by 4 times VTI times heart rate divided by the birth rate will give you what is called as left ventricular output. This I don't want to go in detail, you'll get everywhere. So this is very important to look at volume overload. Okay, next slide, please. Yeah, this is, I told you volume would be finished. What is pressure loading? Carefully you listen here. Pressure loading is what? I have put two important pictures here, what is called normal preterm and normal term. You see the difference between the normal preterm. There is a ratio called as E by A ratio. What is this E by A ratio? Left ventricle is like a Narayana, he'll be sleeping in the initial phase. What exactly happens? All the blood that enters into the left atrium, it goes into the left ventricle with no action of the left atrium. That we call it as E wave. What is A wave? After 70% blood goes from left atrium to left ventricle, remaining blood, left atrium contracts. Then the blood goes. That is called as A wave. So you got E wave and A wave. Then you may ask me a question. So what is this normal preterm showing is like this? E by A. E is lesser than A. But normal term is showing E is more than A. But you're talking both are normal. You should understand. In a normal baby, myocardium is anatomically and functionally well. Because anatomically and functional, diastolic function is good. That is the reason it allowed 70% of blood entering to left atrium to the left ventricle. That's why I got E is more than the A. What happens in the precordium? Virtually, if you look at it, has got intrinsic inherent of not matured properly the myocardium. Because the myocardium is not functioning well, the functioning of the diastolic function of the heart is mainly dependent on the maturity of myocardium. Because the myocardium is not matured, E is not attained to that level, so E is lesser. And this fellow, Papa, what has happened? The blood goes into the left atrium. It has to pump too much blood because circulation is too much in the pulmonary circulation. Blood enters to the left atrium. Too much blood goes. Then what happens? Before the Narayana, the left ventricle, he finishes his relaxation. Somebody opens the gate, it just goes. That is the reason you'll find in a pathological condition, E is more because before the relaxation, what we call isolimbic relaxation time, because before the relaxation happens, blood entered into the left ventricle, you will find in pathological condition, E is more than A. Because of the intrinsic problem, diastolic flow is low in the initial phase, that's a normal preterm will have lesser E wave. That difference you should have when you correlate E by A ratio. Because sometimes what happens, there is always the mention that E by A ratio more than 1.1 is significant. But a poor fellow, when he does the echo, he suddenly looks into the term baby. He sees that E by A, then he puts abnormal. But term baby, even if I go for echocardiography as an adult, E by A is more, that is normal. But in a preterm baby, when baby has got significant ductus arteriosus, the E wave is more than the A wave because too much blood goes before the relaxation happens. That is the reason E by A is more, but relaxation time is low. That is why we call isolimbic relaxation time is reduced in significant area. Next slide, please. Yeah. Once I finish, I told you I am looking at two things. One is what is happening into the pulmonary circulation. I finished that part. Now I am coming to systemic hypoperfusion. Any baby with significant period, don't look at only those areas, look at somewhere else. Two areas always I look at. One is the brain, the other one is the tummy, that is the mesenteric circulation. For that, I look at I use what is called abdominal aorta. If I see abdominal aorta, you will not find, basically, you will not see what is called as reversal of diastole. If you see here, sometimes you get only diastolic flow and antegrade flow. What you see here on the left side, if you see, when I put a probe in the subcostal area with a marker facing to the facing up, I'll see this view where exactly I'll see what is called as abdominal aorta, and there I'll put a probe. I'll get what is called as flow here down. Can you see the down flow? And then you get antegrade diastole. This is systolic flow down and antegrade diastole. But what happens if there is a hemodynamically significant PDA? You will find reversal of the diastole. You can see on the right side. On the right side, what has happened? Diastole flow. It is reversed. You can see diastole up to the diastole. You can see that here on the right side. Down is the systole, and up you can see the diastole is reversed. You can see diastole reversed, and that diastole reversal is very significant. This is called as heel phenomenology. This is one important thing. And also you can do that. You can keep your pulsar Doppler in the abdominal aorta, or two important arteries, celiac artery. You can see CA and the superior mesenteric artery here. And even if you put pulsar Doppler, you will get the flow there. Remember that if you see any flow there, that is reversal or increased resistance, think of that there is some systemic hypotension. So you see, this is another one I have put here. This is called middle cerebral artery on the extreme right. This is a baby which has hemodynamic significant PDA. When you were assessing, initially it showed resistance, increased resistance 0.980. Now diastolic flow is reversed. So this reversal of diastolic flow or increased diastolic flow, increased resistance, to always give an evidence to say that whether you are dealing with a hemodynamically significant PDA compromising your systemic circulation. Next slide, please. Yeah. So that means we look at in a chronology. If you look at a baby with in the initial phase intraventicular hemorrhage, that's the end organ, always assess. The second part, necrotizing encephalitis, you can see here the X-ray, mid part of this part. That is your chronic lung disease. The central one is your necrotizing encephalitis, that is hematointestinalis, and you can see on the extreme right, this is intraventicular hemorrhage. So look at these organs properly, and then I know that everything here is actually given by your clinical scenario. Please make sure that a baby on day 3 suddenly starts to behaving differently. Hemoglobin from 10 or 12 or 13 coming down to 6 or 7. There's a big bleed. Suddenly baby starts to not to tolerate the feed, abdominal distension, think of something, and baby is stuck on respiratory care, long time, chronic lung disease. So give importance to the gestational age and chronology, because if you look at the modern scoring systems, they always include the gestational age and chronological age also. Next slide, please. Yeah, in the nutshell, if I want to see hemodynamically significant PDA, remember, for audience like for the people who are just graduating, make sure that please give importance to clinical features. I don't know how many of you have echocardiography bedside, or you are luxury to have echocardiography. Please make sure that your clinical features. If you are not strong enough to say something, don't touch your equipment. The second, give importance to the age. Which baby you are dealing with? Are you dealing with a baby always in your unit more than 30 weeks? Are you dealing with a case of 23, 24, 25 weeks? Give importance. We are luxury for some reason in our country, at least they are getting more than 28, 29 weeks rather than 26 weeks. Most of the data is less than 26 weeks. Remember, echo will come. You will be looking. The echo is only you look at the God later, but make sure that the bottom line age, all these characteristics needed to be taken into consideration. Forget the echo. If you have the luxury, it will augment your idea. It is always remember, it's always a knowledge versus wisdom. Okay. Next slide, please. Yeah. So I have finished one part of the story of PDA, where PDA, whether you like it or not, time may come, you may close it because of so many reasons. But that's why it's called PDA, because there is a pain or boom. But remember that in the luxury of management. At the end of the story, please don't start looking at closing the PDA. Please give importance to whether this PDA I like to have at this moment. Recently, we had a baby, a term small for gestation age baby, the female neonate born, is diagnosed pulmonary atresia with intact ventricular system. She fled immediately after birth. The heart rate 130 beats, the respirator was good, and saturation, prerectal saturation was 78, not improving the oxygen. The X-ray demonstrated right atrial hypertrophy. The echocardiogram demonstrated pulmonary atresia, restricted ASD, and hyperplastic tricuspid valve also. The ductus was patent and about 2.5 millimeter in diameter. Would you like to treat this? No, isn't it? Next slide, please. Yeah, this is what exactly we saw. So this is right atrial hypertrophy. This had a diagnosis of the pulmonary atresia you can see here. And if you see on the right side, the first one here on the left side, sorry, on the left side, that's the first one. You can see the atretic pulmonary band. This is your aorta and your pulmonary artery division, and this is the atretic pulmonary. This baby behaved, and you see after we started immediately the prostaglandin, baby continued to behave well because here this is a scenario where you have to keep PDA. You're praying for please don't close. You start prostaglandin. Second thing, what happened? Prostaglandin is not enough. 3 days or 4 days. You need to have what to do. Then we had this baby also has got ASD. This is a restricted ASD baby has. But this restricted ASD, you can see here on the left side, second one. This is ASD, and this was small ASD. At any point of time it will close. But I want two things here. The flow should happen across the ASD. That's one part. Second thing, when flow happens, it has to go to the pulmonary artery. But from pulmonary circulation, how does it happen? So two things we did. Initially, we did what is called as septostomy. You can see on the right side first one, the septostomy was done. This is called the septostomy, the intra-atrial septostomy, where the flow happens properly. Then that was not enough for us when we did what is called as stenting of patent ductus arteria, because this is a candidate for blood off tossing. But instead of blood off tossing, nowadays some of the units they do what is called as PDA stent. After PDA stent, they started to improve well and got discharged. They are actually they are in the follow-up at the moment. So what I'm talking to you is, you have two scenarios: PDA, shall I close or not? Second thing, no question, you have to keep PDA. This is another important. The next slide, please. Take-home messages. It is present in the newborn period, but unfortunately, it doesn't know the fate, whether I'm going to stay or not. Clinical signs are critical before calling for echocardiography. It is only, I don't call it as a gold standard in our lifetime. I call this as an extension to your physical examination. Treat the clinical indications, not the echo findings. Direction of flow is very crucial in the management. The presence or absence of is at the mercy of treating physician. To me, if I want to define PDA, there is still poverty in defining and assessing significant. Thank you. Yeah.
Thank you very much, sir. I think this PDA, we will keep it, sir. PPHN, we'll have it another day, sir. Is it okay? Because it will be too much for the audience. That's what they are messaging. What do you say, sir? Is it okay to have PPHN another day, or shall we finish today? So is it okay, sir? We'll have another day this PPHN. Venkatesh, sir? Stop sharing. Prashanth, yeah, you can start your thing. Sir, Venkatesh, sir?
I don't think Venkatesh sir heard this, sir.
Venkatesh, sir? Venkatesh, sir? Can you hear me? Yeah, I think you can start. You can start sharing your things. I will have PPHN on another day.
I'm not.
Sir, can you hear me, sir?
Hello.
Hello, sir. Can you hear me? Can you hear me? Yeah, Prashanth, you can start presenting.
Just a second.
Start sharing. Start sharing.
You're now connected to Boat Rockers.
Am I audible, sir? Am I audible? Yeah, I can see that people can hear me. A very good evening to everyone. At the outset, I would like to thank NNF Karnataka for giving me the opportunity to interact with so many people. So we have had an engaging talk from Venkatesh sir, so about PDA. So we saw how the cardiac hemodynamics looked like with your PDA. So now I'm going to look at and discuss about the heartbeats. So all of us know that arrhythmias are nothing but the disturbances in your heart rate or heart rhythms. All right. So like sir also had a disclaimer. So I'm not a cardiologist. All right. So and my second. Secondly, I should concede that as all of us probably skip those 2 to 3 chapters in Nelson's when we read up for our exams, right? For the chapter on arrhythmias. So I know how tough it is. So my aim is to make it make it a little simpler. And I want to look at from a neonatologist point of view. And probably it will help the residents get stimulated. So another important thing what we need to understand is, so when we are suspecting rhythm abnormalities, so we need to have pediatric cardiologists involved right from the acute stage. So starting from the word go. So this is very important. So we shall go through the normal conduction. So how does it happen in brief? So classification of arrhythmias, we look at abnormal rhythm with fast heart rates, abnormal rhythm with slow heart rates, abnormal rhythm with approximately normal heart rates, and we shall discuss some cases, so to probably keep you engaged. And at the end of it, we will look at some approaches, approach to diagnosis and how to manage these cases. So the impulse generation, as you all know, it occurs from the sinoatrial node. So it's a simplified. It's actually called sinus node, and it passes through the internodal pathways. Okay, just a second. Yeah. So the conduction goes through the internodal pathways, and we have the AV node here, and then the conduction passes again through the ventricle, to the bundle of S. So this is just a picture which depicts an AV node. So where we can see the internodal pathways here. We have AV node here, and subsequently the right and left bundles which are going to the ventricles. So let's look at how yes. So let's look at how a normal ECG is generated. So it starts from SA node. So your atrial depolarization is initiated by SA node, so which causes P wave. Subsequently, with atrial depolarization, when it's complete, the impulse is delayed with the AV node. So you have a gap between your P and Q waves. And then the ventricular depolarization begins at the apex, causing the QRS complex, and the atrial repolarization occurs. So you have your QRS complex here. And then the ventricles depolarize. Once the ventricle depolarization is complete, so then you have your you have a small gap, and then your T wave comes, which represents a ventricular repolarization. So after that, the ventricular repolarization is complete. So this is how your ECG is formed. So I'm sure most of you know. It's just to give a small background. So with normal EEG, we have different waves here. So different segments, and we have complex, different complexes. So QRS complex, and you have a T wave here, and we have PR interval, and you have QR interval. So I'm not going to talk much into the ECG. So to keep it simple, so this table gives the normal values of ECG of newborn. So if you can see this, so there is lot of so it's actually not precise. So it's a wide range. So if you can see, the heart rate ranges anywhere between 120 to 160. It can go from 90 to 230. And PR interval also, you have 70 to 40 milliseconds, the axis, QRS duration, and you have your QTC interval. So the unique feature of the newborn ECG, where we have to calculate QTC interval. So probably all of us know that. And this probably will help us to guide to look at what is wrong where. So I'm going to use this simplified representation throughout my talk today. So where the A represents the atrial contraction or the activity in the atria. And then this arrow will give the direction of conduction of the cardiac impulse. And then the V, which actually represents a ventricular event or a ventricular contraction. So let's look at the normal sinus rhythm. Okay, so you have your A, which from event from A, it is going to ventricle, and you see it happens. And when we look at it, there is a gap between the A's are the same, gap between B's are the same. So it is a normal sinus rhythm. So, and we see that all the impulses from atria are being conducted to ventricles here. Okay, so your AV ratio becomes 1:1. So 1:1, and your A is regular, right? So your V to V is also regular here. So with this in background, so let us classify neonatal arrhythmias. So based on the site of origin of irregular rhythms, neonatal arrhythmias can be classified. So the things which arise from sinus node, you can have sinus tachycardia and sinus bradycardia. And from atria, you have atrial flutter, you have multifocal or ectopic atrial tachycardias or premature atrial complex. So just to tell you, the columns on to the left of you are showing the arrhythmias which causes increased heart rates or fast heart rates. The columns on to your right are actually representative of a decreased heart rate, slow heart rates. All right. So, and then you have problems in your conduction pathway where you see different arrhythmias occurring here. So you have WPW syndrome, you have concealed accessory pathways, AVNRT, junctional tachycardias, and on the other hand, you have heart blocks, which actually causes decreased heart rates. And the ones which, the events which happens, which are happening from ventricle can cause ventricular tachycardia. And the one which, and in ventricle, you also have premature ventricular complex, which actually slows down the heart rates. So it might look very, the jargon looks very complicated. So when you look at this table, so as we, as I take you through this topic, so probably it will become a little easy for you to grasp all this. So just let's look at abnormal rhythms with fast heart rates. So we had a case which was an inborn baby. It's a 38-weeker, well baby, but this baby had unusual tachycardias from birth. So what we noted was it was fixed rhythm. So whether the baby would sleep, whether the baby is awake, the baby is feeding, the rhythm was fixed. But the baby was hemodynamically stable, as I said, and the heart rate was varying between, say, 210 to 220 always. So what we did, we shifted the baby to an ICU, and like all of you would do, we put the baby on multi-channel monitor and see what we found. So we had P wave, we had Q waves. We saw the QRS complex. If you can appreciate, it's all very, very narrow, and it looks like almost a line on the multi-channel monitor. So we got an ECG done. So where we saw the heart rate being high, and there was absolutely no difference between the two beats, and it was a narrow QRS complex. So between this, we did some intervention which normalized the heart rate. If you can see the heart rate, so this is not represented in the multi-channel monitoring in this. So it was around 212, and we did something which actually normalized the heart rate to 138. So let's let's go through this case. So this obviously is a case with increased heart rates. So when there is increased heart rates, what comes to our mind is always a sinus tachycardia, the heart rates being high. So what we see in sinus tachycardia, so as we saw in normal rhythm, so you have the same components of it. Only thing is it's all closely followed. So that is, you just have your heart rates which are increased, but the rhythm remains the same. And so these two, the interval between the atrial event and ventricular event, and this is the interval between a ventricular and a atrial event, if all of you can appreciate. So the interval between the atrial event and ventricular event is less when compared to ventricular event to atrial event. That means to say the P wave is close to your QRS complex, and from this QRS complex to the next P wave, there is a large difference. So this is normal. We all know that. So this just gets squeezed in a short interval of time. So we get sinus tachycardia. So we all know the sinus tachycardia occurs as a result of systemic disturbances like fever, pain, hypoxia, dehydration, cardiac failure, some drugs, hypothyroidism, etc. So the close differential diagnosis for sinus tachycardia is SVT. We all know that. So even in this, when the babies are having sinus tachycardias, we see that our QRS complex will be very QRS complex will be narrow. That's because our baby's heart rates are much higher. So the closest differential becomes a SVT. So what do you mean by SVT? So we all talk about, so when the topic of arrhythmia comes in newborns, the first thing we talk about is supraventricular tachycardia. So what is supraventricular tachycardia? It includes all forms of paroxysmal or incessant tachycardias, that is everything under the umbrella of increased heart rates except ventricular tachycardia. So this is classically characterized with narrow QRS complex. And the other thing is it requires atrial tissue, that is, it involves the atrial tissue and or the AV node as a part of its arrhythmia substrate. So the conduction pathway would involve these two or either of it when it creates a problem. So what are the mechanisms through which this supraventricular tachycardias happen? So you need to understand this concept of accessory pathways here. So you have the normal conducting pathway which goes from AV node to bundle of fists. So that's a normal pathway. So what if heart has another pathway which makes the impulse go back to the atria? So now we say it goes to QRS, there is depolarization and there is repolarization. Instead of it, the impulse just goes back to the atria through a channel. So this is not normal. So we call it as accessory pathways. So we can have AV reentrant pathways, that is atrioventricular reentrant pathways, which causes tachycardia. So that is the pathway is in the somewhere else other than the AV node, or your AV node itself can have an accessory pathway. All right, so it's called nodal reentrant AV tachycardia. And you have increased automaticity higher up, that is your atria. So where the automaticity, instead of firing at normal rates, your SA nodes fires at a very increasing, very fast heart rates. So where your heart rate is high, but it's abnormally high, your QRS complex is still narrow here. And the other example of automaticity is junctional ectopic tachycardia. Instead of your sinus node triggering, you have your ectopics, which is at the junction, which actually triggers it. Junction in the sense it's in the pathway just below your AV node. We will go through each one of it in the subsequent slides. So I talked about reentrant tachycardia. So as it says, AV means, so there is atria which is involved, there is ventricle which is involved, there is reentrant. Means to say there is something which is getting re-entered into your atria. As simple as that. So let's look at our same illustration. You have impulse going from atria to ventricle, and here instead of going to the next beat, so what happens is there is a conduction which going from ventricle to atria. So this green arrow represents an accessory pathway, and your atria gets activated. Instead of getting activated from SA node, this one will get activated, and this again will go back to the ventricles. So this from the ventricle, there is an accessory pathway which carries the impulse back, So like this, it actually goes. So we need to understand that the green, the accessory pathway, which is represented with green, it's abnormal here. So here you have your atria to atria, which is regular. So the atria to atria event is regular. The AV ratio, so AV ratio in the sense the number of atrial events versus number of ventricular events could be normal, but in some cases, so on one of the beats, because it's very fast, it's actually going very fast into the atria, it's not getting conducted to your ventricle. So you can have a skip beat in between, so it can cause AV block. So this gray color arrow represents that AV block, and then a normal atrial contraction starts and then the ventricle goes up. All right. So if you look at those, the events, so the atrial event, ventricular event, and subsequent atrial event. So we said the AV interval, that is from P wave to Q wave, QRS complex is narrow when compared to QRS2, the next P waves. Here the opposite happens. So the relative interval between the atrial event to ventricular event is more when compared to the ventricular to the next atrial event. So because you have a accessory pathway which is actually triggering your atria fast. So this is a representation of it. So as you can see, you have your sinus node. Sorry. So please let me know if you have any queries or if I'm not audible or something, because I'm not seeing any feedback here. Right?
You're doing good. You're doing good. Please go ahead. Everything is very, very clear and concept, and everybody is enjoying. I'm getting a lot of feedback.
Thank you, sir.
Definitely. Yeah. Please go ahead. Please go ahead.
So this is the representation heart-wise. So you see this, the AV node here, and you have your bundle of this. So the internodal pathway would come and it would go like this, and probably it would end here. So this would have been the normal thing. Sorry. Okay. So I'm talking about this figure. Sorry for the confusion. So you have your AV node, so which is conducting, but here instead of stopping here or repolarization happening, what is happening is it is going back into this, because there is a necessary pathway which is letting the impulses go back to the atria, and you can see that this atria is getting activated prior to this. So what happens is this circle keeps going on and on. So this looks like anti-clockwise, right? So anti-clockwise, it just keeps on going. So if you can notice it, so the first event probably looks like happening here. So you have a QRS complex which is formed. So the QRS complex, and then the thing is going back and it's activating the atria again. So instead of the impulse starting from this, so you probably in the ECG you will see a QRS complex first, followed by your P waves. But the thing to be noted is your P wave will be in the opposite axis. All right. So this is called AVRT orthodromic. So that is it is going counterclockwise, and it's involving atria and ventricle, and you have your reentrant tachycardia. So reentrant means it is re-entering and it is causing tachycardia. As simple as that. All right. I hope I made it clear. So what happens if the conduction happens opposite? So I'm not going into the concepts of why it would happen opposite, or why it happens to that other thing. So it probably, I think it's beyond the scope of this. So suppose if it happens, say reverse. So your impulse is actually going to the atria. So from atria, this accessory pathway is conducting instead of your normal AV node, and it going to the ventricle, and from ventricle it's picking up, and from ventricle it is going back again. So here also you see this accessory pathway. So instead of going from atria to ventricle, so this one is going from ventricle to atria. All right. So what is happening here? So let's have a look at it. So here it's actually starting. So it looks like it's starting here in the atria. So you have a P wave, but the axis is not correct here. So the axis could be different. So you have your P wave, which is conducting into the QRS complex, into the ventricle, which is forming your QRS complex. So you have your broad QRS complex, but your P wave is preceding your QRS complex. So this is called AVRT, but it is antidromic. So we saw this as orthodromic. This one is antidromic. So this is just opposite of it. Okay. So why I'm insisting on all this is because, I mean, these are the small things which we can pick up to probably diagnose one arrhythmia. So the concept is as simple as this. So we also talked about WPW syndromes a lot, right? So here the ventricle gets normally excited, but there is an accessory pathway here. So which actually conducts probably both ways, all right? So what happens if both of them are, so suppose there is a impulse here which is being conducted through a normal AV pathway, and then this accessory pathway also takes place. So simultaneously, if this happens, so what happens is you have the activity of the yellow is represented by a QRS complex, and the activity of this, an accessory pathway which is represented in blue is represented here. So at the start of your QRS complex, since it's both in the same directions, you have your normal P waves, but your excitation is happening a little earlier when compared to yellow. So the blue starts off first, and then rest of the yellow starts off, and you get a QRS complex which seems to be a little wide, but actually this is the delta wave. So there is a small inclination which happens because of this accessory pathway. So here in this WPW syndrome, so the passage of your impulses could be bidirectional. So if it happens in the same direction like this figure is representing, you get this kind of classic picture of your WPW syndrome, which is the diagnostic of it. But so as we saw in the previous slide, it happens clockwise or counterclockwise. You will just see your tachycardias, narrow complex tachycardias. So this is just an example. So where a baby had narrow complex tachycardia, so they were not able to find out what it was. And then finally, after few days of cardioversions, that is normalizing your tachycardias, they saw this delta waves which are very obvious. I hope all of you can follow this. You have this here. So you can see the difference between this QRS complex versus this QRS complex. So mind you, WPW syndrome, so to diagnose in your ECG, you should normalize your heart rates. All right. So till now we spoke about the things which are happening from atria to ventricles. So let's look at if something happens in your AV node. Okay. So here, the circulation, whatever we saw, so it's happening inside the AV node. So it is not requiring any other accessory pathways like we saw in the previous diagrams. It is all sealed, but the only vent is this. So it can go either ways. So it can circle anti-clockwise or it can circle clockwise. So, but what happens is if it circles clockwise or either anti-clockwise, you have impulses conducting both towards your atria as well as ventricles simultaneously. So here you won't be able to differentiate a P wave and QRS complex. So you probably will see a P wave which is superimposed here. All right. So because it is happening, so the circulation, the circle is happening here, and it is going up and down simultaneously. So this is AV nodal reentrant tachycardia. We were talking about AVRT in the previous slide. So now we have introduced N because the accessory pathway is in the node, AV node. So what if we have a pacemaker other than your sinus normal SA node? Okay. So if you have on other ectopic, which actually is triggering your heart rates, so it is called ectopics. Okay. For example, in this, there is one particular region which is constantly triggering your atria, and the impulses are going forward. So if you can see the P wave obviously will be in the abnormal axis because it's not coming from the sinus node. So this P waves precedes QRS because the conduction is happening because the ventricle is contracting from the impulse generated in the atria. So, but here, not all of these will get conducted because they trigger very fast. So the load on this AV node is too high. So some of them will get filtered, and some of it will get passed on to your ventricle. So this is how your ectopic atrial tachycardia ECG looks. So, and there is a typical phenomena which has been described. So there is warm up and cool down phenomena where this event keeps increasing or decreasing based on different states. So what if your atria has multi focal, multiple foci. So like in this, so sorry, here we saw there is only one focus which is constantly triggering, but here in this figure, if you see, there are multiple things which are triggering, so all in different directions. So here you see the there is P wave which is abnormal here, but it is uniform, right? So you see this P wave is identical to this P wave, but it's you know, the abnormal P wave complex. But here you see the P wave is very different from each other because it's all arising from different ectopics. So there are multiple different P wave morphologies, and it looks very bizarre and chaotic. And since the rate which are originating here is different, so probably the rates going on to your ventricles also will be different. So we have different RR intervals. So that is different ventricle to ventricle events here. So you can see this one is different from this. Okay, so it's because of your multifocal atrial tachycardias. Okay, and then coming to this concept of permanent junctional reciprocating tachycardias. So here the conduction is mediated by a concealed backward conducting accessory pathway. In the sense, I'll just show the next figure first. Sorry. So you have a concealed backward conducting accessory pathway which is slow. So this pathway will behave like a AV nodal pathway. All right. So what happens if you have a pathway which is equally competent like your AV pathway? So just look at that previous one. So you have your atrial event going on to ventricular event, and ventricle. So you have from ventricle you have an accessory pathway which is going back to the atria, and from atria it's conducting back to ventricles. Again accessory pathway from ventricle to atria to ventricle normally through AV node, and then ventricle to atria, and like this. So if you see this, we had different. We have the same reentrant pathway, but what we need to understand is, so here the interval between the atria to ventricle, so that is the duration between your P wave and QRS complex is less, but your V to A interval is again more. So here your A to A is regular because this accessory pathway is good enough of conducting the impulses well. So it has regular, but the heart rates are more. So here the AV ratio is also maintained because all the impulses are getting conducted. There is no overload in the atrium for your AV node to block some things, and you have your ventricle to ventricular events which are regular, which will equate to your atria to atria. So this is called permanent junctional reciprocating tachycardia. The key word here is the permanent. Okay, so because it acts like AV node, so probably it might become permanent in the heart. So this is just a representation of it. So here again, because the conduction of impulse is in the different direction, you have inverted P waves. And here, if you can, if you give adenosine, so which probably will block AV node, it also would block this also with equal efficacy. So probably you will be able to unmask this tachycardias. So these are the ones. So if your re-entry, so all this while we talked about the re-entry which is happening between your atria and ventricle, whether it was going from a different pathway outside your AV node or it was happening inside your AV node, right? So what if it happens only inside the ventricles? Okay, like you see here, so from atria, it is the impulse is going to ventricle, but this is not conducting back. So this is normal. So you have a normal QRS thing here. So here, so from the atria, one of the impulse is going and triggering the atria again, and this is triggering the atria again. So this is kind of having a reentrant within the atrium, so where it is not involving your ventricles here. So we have your very, very high atrial rates here, which is re-entering. All right. So just to animate and show you, you have your normal A's to B, and you have other thing which is exciting the atria again and atria. So here you see that the load on the AV node is too high because the atria is firing at a range of almost like 300 to 500 beats per minute. The AV node can't take it. So some of it is getting filtered here and some of it is actually going. So your A to A will be regular. So that is your P wave will be regular, but some of it will get filtered. So there will be blockades. but your ventricular rates will be regular, and possibly it will be normal because your AV node is working fine. You can see this. So just to animate and show you, so you have, so this is how it goes. So you have, so block 1, so atria, again conducting back to atria to ventricle, but atria to atria again, this is getting blocked, and then again atria to atria, this is getting conducted. All right. So just to represent in a picture, so this is how it is. So we have this one going going on like a circle. So where it is going on, where it is triggering, where this pathway is touching all the sides of your right ventricle, and only some of it is actually going because your AV node is fine. So here you can get rates up to 500 beats per minute. The ventricular rate would be slow. And you see a typical sawtooth flutter wave. So even in ECG, we always find at some point of time some isoelectric point. So here the atrial rates are so high, so you won't get an isoelectric point. So you just will get a tooth flutter waves here and interpose with your QRS complex. All right. So this is called atrial flutter. So we talked about all this. So we talked about the entry happening between the atria ventricle. We talked about the communication happening within the atria and causing problems. So what if a problem is happening in the atria, but it is getting confined to atria? So this phenomena is called junctional ectopic tachycardia, where your AV node, or just below your AV node, it starts conducting fast. So this conduction is much more than your sinus node. So your impulses from your normal sinus node is not getting to the ventricles. So here your junction itself is produced, has become the pacemaker. So, and it is going to your QRS. It's actually going to your ventricles. So you see your A to A, which is regular and normal because your sinus node is not touched. So AV ratio becomes less than 1:1. That means to say your atrial events are actually less when compared to your ventricular events. So that's why the ratio is less than 1:1. So since you are so the pacemaker is probably acting rhythmically, so you get regular V to V, and you also get increased rates in the ventricle. So here you get a complete AV dissociation, narrow QRS complexes, and if you see the ventricular rate faster than the atrial. So this is nothing but junctional ectopic tachycardia. Okay, so I think we have had too many things. So let's dissect all this and see how we get to the diagnosis, right? So when we look at a narrow complex and we are thinking of tachycardia, so SVT basically. So we're going to look at P to QRS ratio. That is the number of events which are happening in the atria versus number of events which are happening in the V. All right. So we need to see whether it is equal. That is 1:1. We need to see if the atrial events are more than the ventricular events, that is the ratio more than 1:1, or if the ventricular rates are more than atrial ratio. That's all, as simple as that. So nothing complicated in this. So if your events are equal, 1:1, so I'm going to look at the QRS to P interval. So what does it mean? QRS to P interval means to say a QRS of this cycle to the duration of the next P wave. So I'm talking a little reverse here. So if in this ECG rhythm, my P waves, if they are not visible, then it is AV-NRT. So AV nodal reentrant tachycardias. If my QRS to P interval is less, that is my V to A is less. So, and it follows a QRS complex. So it is orthodromic AV-RT. And if this interval becomes more, then probably I'm dealing with permanent junctional reentrant tachycardia or ectopic atrial tachycardia. These are the differentials. Suppose my atrial rate is more than ventricular rate. I'm going to look at the atrial rate. I see if my atrial rate is regular, if it is variable, or it is chaotic, right? If my atrial rate is regular, so probably I'm looking at an atrial flutter. If my atrial rate varies, like, we saw the warming up and cooling up phenomenon now. So if it's variable, my atrial rate is variable, probably I'm looking at the ectopic atrial tachycardia, which is triggering from the same point. And if I get a chaotic atrial rate, so probably I'm looking at a multifocal ectopics which are triggering my tachycardias. So this is as simple as that. So if my ventricular rates are more, we all know probably it is arising below the AV node or just below the AV node or AV node. So that's called junctional ectopic tachycardias. So this is how you approach a narrow QRS complex to arrive at a diagnosis on ECG, or I'm talking about a multi-channel monitor sometimes. So is there any other improvisation on that? So when we see a narrow QRS tachycardia, what we can do is we know the culprits are these pathways. So is there anything which we can block these pathways and see what's happening? Yes. So we can introduce IV adenosine here, which block these pathways, and see what happens after this. So if there is no change in the heart rate, probably I've not given adenosine well, because we all know how complicated adenosine. So we'll just come to it in the next slides. And probably I'm actually giving an adequate dose here. So adenosine should cause some variation in your ECG. If with IV adenosine there is gradual slowing and then the reacceleration of rates happens. So there is the tachycardia is there. You give adenosine, the heart rates come down, and again it increases. So probably here I'm dealing with a sinus tachycardia, or atrial tachycardia, or I'm dealing with a junctional tachycardia. So these are the three differentials I have if there is gradual slowing, then normalizing of the rates. Normalizing in the sense, again going back to the abnormal rates. If there is sudden termination of whatever problems which are happening, then probably I'm dealing with a AV nodal reentrant tachycardia or a AV reentrant tachycardia. The accessory pathway probably is in a different different site in the heart, or the accessory pathway is within the AV node. So if there is persistent atrial tachycardia with transient atrial block which is going back, so then probably I'm looking at an atrial tachycardia. I'm looking at atrial flutter or atrial. So otherwise, other forms of ectopic atrial tachycardias. That means to say, so AV node is getting blocked. So there is normalization. So there is normalization for a bit, and then the AV node open, and the same thing will probably continue. So the effect is transient. So I'm dealing with atrial tachycardias here. So these two probably slides will differentiate most of your narrow complex tachycardias. So once we come to the diagnosis, so probably we might not come to the diagnosis, immediately, because these are all very acute events. So probably one might sit back and look at the ECGs and probably the next day will interpret. Okay. So, but whenever there is SVT, the things what we need to do. So the most important thing is we need to stabilize the baby, right? So we need to stabilize the baby. We need to stop this SVT which is happening. So we need to see whether the baby is hemodynamically stable or if the baby is hemodynamically unstable. If the baby is hemodynamically stable, like in the case which I just said, so this baby was having narrow complex tachycardias, but the baby was hemodynamically stable. So what you can do is, so you can put a 12-lead ECG as soon as possible, or a multi-channel monitor, and abort this by applying ice to the face or by giving IV adenosine. But IV adenosine definitely preferable to ice to the face. So especially in newborns. So what I'm doing with this is I'm increasing the vagal stimulation. So I'm blocking the AV node and seeing if the SVT terminates. If there is no response, I'll still look at my cardiac function. So probably we will consider a beta blocker. The choice probably depends on center to center and pediatric cardiologist to cardiologist. So esmolol is a good example. And even with a beta blocker, if there is no response, so probably we might consider other antiarrhythmic class like propranolol, flecainide, propofenol, amiodarone, and diclofenac. So I'm not going into the depths of when to use this and all. So I'm just going to give you just an overview of when to use all this in the next slide. So I have increased my vagal stimulation. So I've given a beta blocker. There is no response. So probably I used another line. So if the baby is not probably responding and the baby is probably going to hemodynamic instability, there is no other way other than stopping all the conduction in the heart and restarting the heart. So that is by direct current cardioversion. So if the baby is hemodynamically unstable to start with, you might still start with IV adenosine. while you are keeping your cardioversion ready. All right. So hemodynamically unstable, the take-home message is, so hemodynamically unstable SVT, so DC cardioversion, probably IV adenosine in the gap. So if it's hemodynamically stable, we have a scope to introduce medications here. So these are the different drugs which have been used for the treatment of SVT. So I'm not going to go into each one of them. So I'm just left the concepts with you guys. So we can use adenosine, digoxin, propranolol, flecainide, sotalol. So the thing is, suppose if the baby's heart rate, the baby's cardiac function is not good, so digoxin probably could be used here. So, but if there is any pre-excitation, so the digoxin can worsen the tachycardia. So probably we need to be careful while we are using digoxin. And amiodarone, to tell you, is the second or third line agent for all the SVT tachycardias, especially in the maintenance period. All right. So does this acute events which we see in NICU stop? Natural history, when you look at SVTs, usually they regress and stop by first birthday. So for a well-tolerated adenosine-sensitive tachycardia, so which was reversed easily, a long-acting beta blocker would suffice to maintain the rhythms. So if a baby has presented to us with a shock, that is hemodynamic instability, the baby has presented to us with an SVT, or in whom the cardioversion was very difficult, so probably we're going to use other drugs. So probably these are the SVTs probably which are difficult to treat. So how long do we need to continue once we start these medications? So as we know that most of it resolve by 1 year of age, so including your WPW syndromes. So most of the atrial, so the prognosis is more if the atrial tachycardias present by 6 months. So most of them will be free of tachycardias after 12 months. So most cardiac centers so give full therapeutic doses until 6 months of age, and then a maintenance dose until 1 year of age. So the respective medications, whatever they would have started off. So here, coming to the same case, so there are no prizes for the guesses. We all know. So the normalization of this within a span of few seconds was because we probably blocked the AV node. So since we did not have adenosine in our NICU, so it took some time. So we applied ice packs on the baby's face. So that was sufficient for it to block. You can see the heart rates which are normalized here. You can see QRS which is widening. You have RR intervals which was widening. So here, so initially we treated this baby with ice packs and adenosine, and then the baby subsequently went on to propranolol. So obviously, with each step we had pediatric cardiologist who was guiding us. So the baby subsequently was put on amiodarone of 5 mg per kg loading and maintenance, and the baby got discharged home. And then the baby was on oral amiodarone, so probably for at least 8 months. So we followed this baby up to 8-9 months by the time the SVT had resolved in this case. So till now we saw the QRS complexes which are narrow except for one. So now we are talking about another chunk called ventricular tachycardia. So all these 5 we are talking about the conduction pathway which are involving both atria and are conducting atria as well as the AV node and conducting pathway. So here in ventricular tachycardia, what happens is, so you have a wide QRS complex. That happens because you have a trigger which is happening in your ventricles. So this trigger probably is nothing but premature ventricular contractions. So other than for the normal conducting pathway, you have some ectopics which probably are firing. So if you have three or more of these sites in your ventricle, so it amounts to ventricular tachycardia, where your heart rate will be above 120 beats per minute. And here you see that the QRS, the complex which is wide and which is bizarre like this, and you see the P wave which is probably getting fused or captured in your QRS complex. Here you have your P here, here the P has come out a little bit away from QRS complex, and then here is your P waves. So this is how it works. So your SA node keeps firing and your ventricle also keep firing. So there is no mix-up of these conductions. So this is ventricular tachycardia. So approach to broad QRS complex, you have not many DDs here. So if it's less than 1, that means to say your ventricular activity is more than your atrial activity. Is no doubt it's VT. And if you have 1:1, so we spoke about it. So antidromic and AVNRT. So where you probably have wide QRS complexes. And so if you have an SVT with one bundle branch also, your QRS complex can get prolonged. So these are the differentials for your broad QRS complex. So here also in VT, we all know that most of us would have experienced VT in the terminal stages of babies with high metabolic problems and stuff. So most of them will be hemodynamically stable for sure. If by chance the baby is hemodynamically stable, we can try medications, but most of them will require DC cardioversion. So that probably will help in terminating. So if a VT leads to cardiac arrest, so one more thing which probably we can also use is your amiodarone, so which has been cited in some literature. So a VT with cardiac arrest, so amiodarone is used in some situations. So this is about, so all these things were about the ventricles which are beating fast, the heart rate which was fast. So now we look at some rhythm abnormalities which causes low heart rates. Okay, this was another case. So this is a case 2, sorry. So this was a term baby who was referred to us on day 2 of life because this baby had recurrent persistent respiratory distress. On examination, we could see the pulse rate of 58 per minute, and there were florid features of cardiac failure. So the hepatomegaly and everything. And with probing, so we could get the mother had some skin lesions and she's on some long-term medications. She also had some renal issues and also finally we could make out the mother probably had an SLE. So I'm sure most of you would have already guessed the diagnosis. So we put the baby on multi-channel monitoring like we do. So interesting facts is if you just look at it, although it's not very, very clear, you can see this a little bit broad complexes which are regular. All right. And you also have a narrow things here, which are also regular. So both of them seem to be regularly going. So the ones which are little broad are the P waves which are represented. So which the monitor has picked it up as the normal heart rate. So which is not. So that's why you see the heart rate being 158. But you see the pulse. So this is from the pulse oximeter. The pulse is just 58 here. So but the total events which are happening in the heart is around 156. So here you see the broad ones are regularly paced. So here the narrow ones also seems to be regularly paced. So seems like the broad QRS and the not exactly QRS, the broad complexes and the small complexes seems to be in their own worlds, right? So what is this? So we look at it. So most of us would have seen sinus bradycardias. Again, you have your normal rhythm. So here you have regular rhythms. Only thing your heart rates are less. So it is spaced. So your sinus bradycardia can happen in various newborn conditions like hypoxia, acidosis, increased intracranial pressure, abdominal distension, hypoglycemia, etc. So here also the same thing will remain from the normal rhythm. Only thing is the heart rate is less. So the intervals is the same. So here is an example where there is a conduction and there is a premature contraction, so which probably is not getting conducted. So the ventricle is not contracting. And again, your atria is contracting and it is going to the ventricles. Again, you have a premature contraction, which is not getting conducted. So this is an example of non-conducted atrial bigeminy where you have another event which is happening, which is not getting conducted, but it is alternate to your normal sinus. So you get a regularly irregular. So regularly you get irregular. So you have these two small and these two being wide. So again small and again. So this is regularly irregular. The number of events which are happening in atria is much more when compared to your ventricle events. So possibly here in this case it is 2:1. So it's called atrial bigeminy because the alternate beats are not getting conducted to your ventricles. So these probably will get resolved within days to weeks. So it could be things. So another classical examples all of us have grown up reading this is your blocks. So this is just an example. So where everything is fine, but one of those impulses won't go, and the normalcy returns. So so this is an example of second degree AV block where your atrial events are regular and normal rate. So your AV ratio, that is your ventricular events, are happening less because of some things which are getting missed here. So, but if you look at your ventricular rates, so it could be normal rates, or it could be a little less, but it is irregular. All right. So this is an example of second degree AV block, morbid type 2. So what happens more frequently? So you have one thing which is conducting, another one which is not conducting, another one conducting, another one not conducting. So this amounts to atrial ventricular ratio. So atrial event versus ventricular events of 2:1. So everything seems to be regular. Only thing is your ventricular rate is less. So you can see and appreciate in this ECG that your P wave seems to be regularly spaced, but so one QRS is missing with alternate atrial conductions. So just a slide which summarizes the different degrees of AV block. So we know the first degree AV block just means to say there is a prolonged PR interval. The second degree AV block will have has two types, type 1 and type 2. So type 1 is nothing but Venkatesh phenomena where your PR interval progressively widens and there is a beat which is skipped. So in morbid type 2, everything seems to be okay, but one beat gets skipped. And if it becomes more and more, so it amounts to 2:1 AV block where every alternate E waves get blocked. So this is 2:1 AV block. And if there is a complete block, so none of the atrial impulses are going to ventricles, you have complete AV block. So where you can think that atrium is in its own world and the ventricle again is in its own world. So just a brief thing about complete AV block. So we know that none of the impulses are getting transmitted from atria. So ventricle beats on its own and atria beats on its own. So ventricular rates typically is around 40 to 80 beats per minute. So I'm looking at it is because probably we might see this kind of cases because the number of mothers probably having this anti-ROLA antibodies are more. So those pregnant mothers who have RO and LA can have this different degrees of heart block. So the extreme thing is your complete heart block. So it can also happen in structural heart diseases, and it also is a part of your. So it's also happens because of anti-RO and LA from the mother, and it can also be acquired post cardiac surgery, myocarditis and endocarditis. So here the treatment remains pacing. So that is permanent pacing, so probably preceded by temporary pacing. So if a baby goes to permanent pacing, these are the indications. If the baby is symptomatically bradycardic and there is ventricular dysfunction or low cardiac output with complete heart block, so this baby will require permanent pacing. If there is wide complex QRS and there is escape rhythm, so wide QRS complex with escape rhythm, so like complete heart block, so this baby will require permanent pacing. And if your ventricular rate goes less than 55, so or if a baby's heart rate less than 50 associated with some congenital heart disease will warrant permanent pacing. So here in this, so we actually got the report of the mother. So mother was RO and LA positive. So we advise pacing for this baby because it warranted, because this baby had cardiac failure. This baby's heart rate was hovering between 55 to 60 throughout, and the cardiac output was less. This baby had all the indication for permanent pacing. However, the parents, did not wish to continue treatment, and this baby left against medical advice. So, and here is a curious case. So this is from my colleague Dr. Bharti. So she shared this case with us. So this was a 30-weeker inborn baby who weighed 1.3 at birth. So this baby was taken up for emergency LSCS because the baby had fetal distress. So we started resuscitating. So there was persistent bradycardia. So this baby seemed to be okay, but for some reason the heart rate remained slow. So according to our algorithm, so we did everything. So we went down to intubation also. Thank God we did the chest compression. But he was intubated since everything was okay. So this baby was brought to the NICU. And here in the NICU, the bradycardia persisted. So here you can see, so we took an ECG and we got an opinion from pediatric cardiologist. So ma'am said it was prolonged QT. Probably it looked like a 2:1 AV block. So, so if you can recollect the previous slide. So for all of a sudden, so this baby started to have this intermittent tachycardias in between this bradycardias. So this was episodes of tachycardias interposed between bradycardias. So when you look at the literature of this kind of presentation, so most of us would have heard about this long QT syndromes. So this long QT syndromes are the one which actually causes this kind of bradycardias and tachycardia yo-yos. So these are the group of genetic disorders resulting prolongation of your ventricular repolarization. So the repolarization is not happening well. So there is a problem in your QT interval. So it is prolonged. And the association is if you leave this QT syndrome to continue, so it leads to torsionis depointis. So where you have different, so that's a complication of your long-standing QT syndrome. Or usually it will be associated with second-degree AV blocks. So 2:1 blocks. It will be associated with. And we need to suspect it when there is a combination of tachyarrhythmias and sinus bradycardias. So the diagnosis in newborns includes looking at the QTC interval. If it's more than 0.47 seconds, it's highly indicative. If it's more than 0.44, so probably it suggests that there could be QT prolongation. So various scoring systems have been developed looking at other things to arrive at a diagnosis, but newborns, I don't think there is any valid study which looked at it. So any presentation with this kind of suspicion with QT prolongations, you need to probably diagnose long QT syndromes. So here the treatment is not to excite the heart much, so we need to use beta blocker, and so probably these babies might require pacemaker for heart block. So looking at our case, so this baby had 2:1 AV block. So echo showed normal heart. So this baby was diagnosed to have QT syndrome. So the baby went on home with propranolol beta blocker. This was discharged on day 40 of life. So this baby we've been following. The last follow-up was around 6 months. The baby was doing well. So now coming to the abnormal rhythms with plus or minus normal rates. So it is not very high heart rates or even very low heart rates. So when you have premature atrial complexes, so where you have a normal atria to ventricle conduction, but you have a premature complex which is not getting conducted, and another one which is normal. So if this happens, so your A to A, so your A events will become irregular. So but you can have normal rates. Your AV ratio could be more because some of the impulses are getting blocked in between, and obviously you can see the ventricular rates which are irregular. So these are the most commonly seen arrhythmias, so as to say, in newborn babies. So most of them would be benign. So most of us would have appreciated these kind of things. A baby who is having irregular heart rate, so you do an ECG and it becomes normal. So these are mostly benign ones. So what if you have a complex which is in the ventricle, so where your normal conduction happening between atria to ventricle, so but you have a premature ventricular complex which is happening. So the next, probably there is a block. So here you find the atrial events being regular. We have normal rates, but the AV ratio is 1:1 or probably less than 1. So because your ventricular rates probably will be more and your ventricular rates will be irregular. So this probably are not seen that commonly in newborn babies. Okay. Sorry, the heading is missing here. Okay. So to just summarize, so we saw the tachycardias, abnormal rhythms. We saw bradycardias, abnormal rhythms, and we saw tachycardia and bradycardias. And we also saw the rhythms which are probably normal. So just to summarize. So just one slide on cardioversion. So sorry, the heading is not coming. So cardioversion is nothing but a synchronized administration of shock during the R waves of QRS, complex of cardiac cycle. So the paddle size which we need to use should be infant size. So all of us know from PALS. And so the interface should be self-adhesive pad. Most of the machines have it, or an electrolyte gel, not ultrasound gels. And Paddle position can be only anterior, so where you put one pad on the right side, upper sternal border, and other at the apex, or it can be anterior and posterior, so making the heart be at the in between these pads. So energy dose is initial dose of 0.5 to 1 joules per kg, and we can increase to 1 to 2 joules per kg if the first shock is unsuccessful. So basically what is happening is it's administering shock to the heart and everything is stopping and the heart is restarting, as simple as that. So coming to adenosine, the dose, we should know that it is 0.05 mg per kg or 50 microgram per kg. We can repeat up to 250 microgram per kg until we get a desired response. And we know how to give rapid push followed by an NS flush with a 3-way. The other most important thing is we need to make sure that the site of injection or the adenosine should be injected as close to the heart as possible. So just to summarize, so though uncommon, these rhythm disturbances can cause morbidities. So one of them is SIDS. So one of the major mortality, so one of the major cause of the SIDS is suspected arrhythmia. So which probably we can pick up in the neonates if you are vigilant. So all sick newborns and suspect rhythm disturbances should be put on ECG monitor and probably get a ECG done. So if you look at tachyarrhythmias, now we know that SVT is more than VT. In SVT, AVRT is the most common. So the treatment may be required for 12 months. So in bradyarrhythmias, we saw heart blocks, so we probably require spacing. And so some of the cases, if there is family history and high index of suspicion, like we discussed, so we need to work up for long QT symptoms. So here, the precise diagnosis is important for acute as well as chronic management. And mind you, so we can't be independent when we are treating or dealing with rhythm disturbances. Always seek pediatric cardiologist help, starting from the word go. So these are my references. I actually could not put references in each slide so as to not to distract people. So these are my references. These are for residents and PGs who can go back and look at these beautiful articles from which the concept have been derived. Thank you.
Yeah, thank you, Dr. Prashanth. Actually, you have become sinoatrial node of all the participants who have been hearing, because that is the place where first heart, the heartbeat starts. So you've become a heartbeat of everyone with your lovely presentation. Extremely complicated topic, but you have made it very comprehensive and very algorithmic, approach of the rhythmic disorders. Thank you very much. So we'll quickly move to the discussion session. I would like to request all the participants to raise the hands so that we can quickly unmute them one by one and we can directly ask the question, or you can just post the question in the chat box. We will take up. So I request Dr. Dinakar sir also to join the session, because more the people, more the merry. I would like to request Dr. Kiran from Qatar. Kiran More. 1 second. Yeah, Kishore sir. Yeah. Yeah.
I'm here.
Yes, sir. Yes, sir. Yes, sir. You can, sir, Dinakar sir, Kishore sir, you can moderate the session and we can start the discussion. Over to you, sir.
Yeah, I think Prashanth has done a wonderful job. Prashanth, thank you very much for making such a dry subject so interesting. Especially the junior staff or fellows are lucky because they're in the learning curve and they can focus on this. Because every arrhythmia looks the same, especially in neonatology. May not be older children and adults. Neonatology, the arrhythmias are very, very difficult to diagnose unless it reminds me of a Bailey and Love. You don't think of what you can see when your eyes, eyes don't see what the mind doesn't know. That's exactly true of these arrhythmias. So hats off to you. Done a wonderful job. Over to you, Prashanth.
Yes, sir.
To take further questions. I can't think of any questions because it was covered so brilliantly.
Yeah, Dinakar sir.
Yeah, excellent. Both the speakers are very good.
I think so, Dr. Even Sharada Gowda from Texas, she might be there. She is actually a electrophysiologist, I think so, electrophysicist. She's there on the line. Kiran is there on the line. Prashanth?
Yes, sir. Yes, sir. I'm just
Dr. Prashanth?
Oh, no, she just messaged.
Prashanth Y N?
Sir, sir.
No, Dr. Prashanth Y.
Dr.
Dr. Prashanth,
sent a message.
can I ask you one small question?
Yes, sir. So I'm no expert, sir. So
Okay.
that's my first disclaimer. I'll try to.
No. I am see, one thing to tell you very frankly, even last thing for neonatology means you can shoot him, he is ready to accept. If he gives him a ECG, if you tell him diagnose, that is, he will only kill himself. He will only kill himself. No, I don't know. You might be expert person, but just I am concluding your talk because I have two questions, that's all. Number one, SVT means instead of, because you told so many things, sometimes if we are in the periphery, if we are not usually reading, sometimes we do forget. SVT means, can I conclude? If I am wrong, please tell me, because people are around, they are listening to me. Number one, SVT means atrial flutter, atrial fibrillation, then re-entrant AV node. Just gross, I am talking about gross. If three things at least, if we are there, because in atrial flutter, definitely there will be 3 or 4 or at least 2. P wave should be there, followed by the narrow Q wave complex. Number one, this is called atrial flutter. Easy way to remember everybody. Number second, atrial fibrillation, fibrillation. At least 1, 2, sometimes we might not see the P wave at all, followed by definitely there will be narrow QR complex. AV re-entrant, sometimes we definitely might not see the P wave, but definitely QR complex short is there. In that, close the eyes. If I am wrong, please correct me. Definitely it is easy to diagnose 1, 2, 3. That's all supraventricular, just above the ventricular tachycardia. So if it is there, can we give adenosine? Can we give adenosine first after ice pack or something like that? Can we give adenosine immediately, or can we start propranolol immediately, or can we after the propranolol if it is not adenosine? Which one is first? Because you told adenosine, then propranolol, then you told procainamide, then amidaron, because amidaron is having its own complications, long term also its own complications. Please let me know. This is my one question, sir.
Right, sir. So let me just share.
Yeah, Prashanth Y N.
Yes, sir. So I'm just sharing again because some of them I've asked the same question like you, sir. Share. Prashanth, sir, how to share the screen, sir?
Prashanth, how to share screen? Gowda.
You can share the screen now.
Just a second, sir.
Yeah.
Okay.
Yeah.
At the same time, when you are okay. Yeah, make the big screen, Dr. Prashanth.
Right, sir. So this is how the algorithm is, sir. So we need to differentiate whether they are hemodynamically stable or not. SVT means, so any narrow complex QRS, so is to be taken as anything under it will be SVT. So first we need to see that, so we need to abort what is happening to see the rhythm. So we need to give adenosine. If adenosine is not available immediately, so probably ice to face also works. And then this is just an empiric treatment which was suggested in Neo Reviews 2008. So we talk about beta blocker and then going to the next one, because mind you, most of the antiarrhythmics also can be pro-arrhythmics. So when we choose this antiarrhythmic, so I think we all should be doubly sure. So we need to involve a electrophysiologist if we have, or a pediatric cardiologist before we go to the next step from beta blocker. I think if nobody is available for my help, so I would probably stop with beta blocker, looking at if my IV adenosine or ice to face has helped. If it is hemodynamically unstable, so probably DC conversion is the treatment. Then and from there on, I definitely would involve the cardiologist. This is again, so I saw some Karthik sir had asked about this. So
Yeah. Prashanth, thank you so much for the. I had the same question which Dr. Dinkar brilliantly asked. The clinical scenario is always a baby coming in with tachycardia and it's an acute situation at the middle of the night. So atrial fibrillation versus SVT is always a confusion. So I believe if you once you give adenosine and you take an ECG, a 12-lead ECG, you can differentiate between the two. Can you just tell us only the differentiating point so that it's a good clinical marker for us?
Okay. So before you look at AV reentrant tachycardia, so the it always
and atrial flutter are regular.
But your AV
Atrial fibrillation treatment is a
P waves, it probably won't look like sawtooth. That is one. And so here the termination happens. So probably it will go on for some time in your reentrant tachycardias, but in your atrial fibrillation, so it immediately goes back to its own. So that's what I understand, sir.
Yes. Is there anything, something like that, Prashanth? We should not give adenosine. See, we know that all the SVTs, adenosine is the best. Later we can go for the second line, like a esmolol or propranolol, whatever the IV. Then the third. Suppose ventricular tachycardia, definitely we do see because of some congenital heart problems or after anything. Usually congenital heart problems like a ventricular septal defect are because some people do come to us with a calcification in the ventricle. Because there was a case, it was presenting like both everything, both SVT type or ventricular type. So during that case, because my cardiologist was afraid to give adenosine, she preferred amiodarone. Is there anything? Is there like that?
Yes, sir. Sir, so we need to differentiate between narrow QRS and wide QRS, sir. If you have wide QRS, adenosine is out. So because wide QRS means, so probably we are not dealing with all these reentrant pathways or something coming from atria. So if we find broad QRS, so adenosine probably has no role in that.
Yeah. So broad QRS, amiodarone is the treatment. Or procainamide.
Yes. So in case of broad QRS, like one of the slides which I showed, broad QRS with heart block. So sorry, broad QRS with probably cardiac arrest. So we'll have to give amiodarone in that case.
Yeah. So easy way to make difficult subject, make it simple. You have done a great job. Thank you very much. Thank you very much. Anybody, any questions? Prashanth?
Yes, yes, sir. Yes, sir. I think few questions for Venkatesh, sir. Venkatesh, sir?
Yeah, Prashanth, I'm here.
Yes, sir. Yes, sir. One question was, should PDA be measured at the most constricted part apart from pulmonary artery end or aortic end? I'm sure you answered that. You can just explain it again, sir, about the importance of measuring the...
Yeah. When you measure, especially when we measure using short axis view, we need to have, ductus has got two parts. One is the narrowest part and the other one is widened part. The narrowest part towards the pulmonary artery and the widened part towards the descending aorta. So when we measure, make sure that the size has to be done at the narrowest point. It's very important. The problem with this short axis view is sometimes we may measure the left pulmonary artery. That is the reason most of the times actually when we want to measure the size, better we use suprasternal view. That is the best way to get the measurement of this ductus arteriosus.
Yeah. Anybody who wants to ask, you can just raise your hands. We can directly connect. I think...
I have one question to Venkatesh.
Yeah. Please go ahead.
Sir, I had two things in this measurement because there are two schools of thought about measuring this PDA with color and without color. So I personally feel, because that's what I've been taught, that without color is best because your color could be manipulated with your gains. Whether you increase gain, so probably PDA will look big, and decrease gain, PDA will look small. But so what do you think about putting color and measuring? Sir?
Yeah, both the measures I agree upon, but if you have a good diameter ductus arteriosus, I think 2D echo is the best. But what happens if you have a big ductus and if you put the color, it widens. If you see the measurement along with this color Doppler, what we have done, we had the same thing. We were reading in the theory, but we did practically. We thought of measuring the ductus at the ductal level, using the short axis view and the suprasternal view. Almost they are matching if you do it properly. But color Doppler always overestimates if you have a big size. In a narrow ductus arteriosus where you don't, very, very small ductus, then I think color Doppler may work. But nowadays, we have fantastic echo machines where you can detect on 2D echo.
Thanks.
Yeah. Dr. Srinivas?
Yeah.
Yeah, you had doubt, you can ask him directly.
Yeah. In case a newborn baby has got one single episode of SVT and subsequently baby looks fine, do you have to start beta blocker on all these babies for some time?
I'm not sure about the answer, sir. So because, I mean, whatever I have read and probably the cases which we have seen, so this transient SVTs is definitely a phenomenon. Like I said, your atrial ectopics and all could actually cause it. If it recurs, so probably it will definitely require management. So what the recommendation says is, suppose if you have documented an SVT, so you make the parents do this, palpating the pulse and ask them to keep a record of how the heart rate is there. If it's recurring, so definitely it would require. So, but most of them, so if it comes and probably gets aborted easily or once in a while it comes, so it is one of those benign SVTs which
require. Dr. Prashanth Y N.
Sir.
Yeah, amidaron, in your slide, you have told we have put amidaron for a long time. This baby has improved after 1 year, everything has become all right. Yes, amidaron, do you think if you'll give 1 year, do you think something will happen to the heart? Because I have read so many things.
Right, sir. So it can cause pulmonary fibrosis and it has got variable this one. So we actually took help from our pediatric cardiologists because they were the primary treating physicians. So from Chattanooga, so they were actually titrating. So thankfully, this baby did not have any problems throughout, and the dose which was maintained was very less. So we didn't find any problems with this.
Because it will cause some myxomas, fibrosis. That is the reason usually they will go for propranolol, I heard.
Right, sir. Yes. Propranolol is safe.
Thank
you. Safe. Yes.
Yeah. Dr. Murali has a question. Dr. Murali? Dr. Murali Raj? Yeah. He has asked weight of the baby to be considered while assessing the size and significance of PDA like ELBW. What is your opinion on Dr. Venkatesh, sir?
Yeah. So it's a good question. So most of the times, actually, it's a good exercise for the beginners to do that. Most of the people, they also have looked at the body surface area. So you look at the body surface area and then look at the size. But to me, it doesn't matter. When I have a PDA, I mean, you know that I told you, the size doesn't matter to me. Whether you say it is a 1.5 millimeter, 2.5 millimeter, 3 millimeter, at the end of the story, if you are strong enough to say that clinical acumen is in favor of that ductus arteriosus, and if I keep measuring every time, it is basically, we should know that it is not the static value, what we say. It is a size, I say 1.5 now 2 centimeter, then I say that, oh, then I'm going to know. Every day keep doing, look at the other scenarios and look at whether it is, you are dealing with the pulmonary circulation, core circulation or systemic under circulation. If you look into that, I don't have much to comment on the size. Size doesn't matter to me. I have seen a small PDA causing a lot of problems, big PDA not causing any problem because systemic and pulmonary gets equated. So I think good exercise for the learners to make sure that body surface area and then look at the ductus.
Yeah, I think Dr. Gautam wanted to add few things on the SVT. Dr. Gautam?
Yeah, can you hear me?
Yes, sir. Yes, sir. Please go ahead, sir.
No, I just wanted to say I enjoyed the presentation, especially Prashanth's was a wonderful talk.
Thank you.
And in response to the question of a single episode of SVT, I would check if there was a transient cause of the SVT, like an electrolyte abnormality or some other thing that has now resolved. And in our unit, probably we would do a Holter monitoring on a baby like this if there was a doubt. And then the cardiologist would make a decision. And actually listening to these talks, I'm just amazed at how much cardiology is being practiced by neonatologists in India. because in our unit, I guess we're spoiled and we kind of outsource all this to the cardiologists. And it's just very impressive to see all of you doing so much cardiology. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you.
There is one question. Any structural heart disease to be considered with SVT, Prashanth?
Sorry, sir.
Any structural heart disease to be considered with SVT?
Yes, yes. So as I said, so some of them, SVT is not a small thing. So it's an umbrella of diagnosis. So probably when we look at SVT, to simplify, we have told it as SVTs. But we need to look at what exactly is rhythm disturbances. As I mentioned, so most of them could be associated with congenital heart diseases, which could be very difficult to treat.
There is one more question. Can medication be given in term neonate for closure of
Most of the times, actually, the ductus arteriosus and term babies will close by day 3 or day 4 or day 5. What we call it as initially is the functional closure, where the intermittent closure takes a long time to happen. So in a term baby, if you see that, most of the times to rule out any structural heart. If I see a term baby having PDA for a long time, I look at any structural heart disease. Otherwise, you get function closure. And if it is really significant ductus, no structural heart disease causing problem, I think I'll wait for some time, depending on the clinical condition, then may require. But usually it doesn't work. Medications, they do not work.
Yeah, I think Dr. Karthik sir has a few questions.
Yes. Now, Prashanth, I just wanted to ask you, I did not see how many doses can you give? Given properly, you expect a response immediately. If it doesn't, then how many doses is the upper limit you can use it for?
So it is, the dose is 0.05 mg per kg, sir. We can go up to 0.25. So that is 5 times we can give 0.05 mg per kg. Has mentioned that you can start with 0.1 mg itself. So the maximum you can give it 0.1.
Mom, he is calling you.
Dr. Srinath?
Yeah, I'm here. This is a question to Dr. Venkatesh. I think Dr. Venkatesh is muted.
No.
Hi, Dr. Venkatesh.
Yeah.
Dr. Venkatesh, excellent presentation. I really enjoyed it. Actually, both the presentations are wonderful. Okay, so, and I just wanted to know, you beautifully explained about the Doppler flows across the PDA and its significance, and also the Dopplers to do the SMA, celiac axis, or descending aorta. How significant it is to do the right angle correction while measuring these Dopplers, because it is not easy to do. If in advanced echo missions, it is easy to do the angle correction, but in the basic ones, I really struggle to find how to even do it.
Yeah.
So how significant it is to do that?
Yeah, that's true, Dr. Srinath, because it's all what is called as operator dependent. What is the thing called angle of inclination? That's very, very important. If I don't angle it properly, and most of these Dopplers, if you see, they're actually, the angle is less than 20 degrees. If I get Doppler of, for example, ductus arteriosus, it is actually the thing goes parallelly. If I see, what's called the 90 degrees, I am very much worried. If it goes parallelly, it's always better. And most of these values you can get easily. There's nothing like, even for example, if I want to take a suprahemiscentric artery or celiac artery, you can get, there is almost, around 10 degrees of high this correction. I think if you go beyond 20-25 degrees, then I think you'll get a lot of errors. And you're right, actually, it is all operator dependent. You get in all the conditions, there's no reason why this angle of inclination should go beyond 20 degrees.
And where do you use the pulse wave Doppler and where do you use continuous wave Doppler?
Yeah, pulse wave Doppler, if I have a, for example, it all depends on the pressure gradient. Suppose if the flow is happening around 2 meters per second, more than 2 meters per second, the pressure, if I want, for example, if I want to have a tricuspid regurgitation jet, the flow across the tricuspid valve is too huge, the pressure gradient, and it exceeds more than 2 meters per second. That is the point where I use continuous wave Doppler. Even in ductus arteriosus, it all depends on how the pressure gradient across the shunt. If the pressure gradient across the shunt is too huge, use continuous wave Doppler. Otherwise, if I use pulsar Doppler, even in ductus arteriosus, pressure gradient is too huge, we get a phenomenon called aliasing, which I am not going to talk to you about at the moment. But what is important is if any pressure velocity goes beyond 2 meters per second, there is a continuous wave Doppler. Less than 2 meters per second, that is ductus arteriosus. Most of the times we do get. Am I clear?
Thank you, Dr. Thank you. Thank you. Very, very clear. Thank you.
There is one more question Dr. Gautam sir is asking about some proposal of routinely screening all neonates with ECG for a long QT syndrome. Opinions from all of you. Venkatesh sir, Prashanth, Dinakar sir.
Yeah. Yes.
Hello. Venkatesh sir, you can start, sir, from you, and then or Prashanth, any one of you can start.
To answer this question, sir, so I actually really don't know the incidence of this long QT syndrome. So since it's a group of genetic disorders, so I did not find any large study from India which probably has looked into this. So although we have very high incidence of sudden infant death syndrome, I think it's a good idea if a baby gets admitted. So if you have the facility done, so why not? So I think we can look at it. I think it's better to screen. So because all it needs is only an ECG and probably some. So because as I was mentioning, there are some 2 to 3 scoring systems which have been validated in pediatrics and adult age group where they have given different scores for different things. So
yeah, QT scoring system.
QT scoring system. So probably we so I think yes.
Venkatesh sir, would you like to add on this?
Yeah. So I give importance to the history also. If there is a family history, strong family history, sudden cardiac deaths that's happening in the family. And I think as Dr. Prashanth rightly said, I think better you screen all babies in the NICU better. And especially those babies who are on some of the medications which prolong the QT interval. That's also important. I think, definitely, I think it is a big study we can do. In India, we don't have specific, even we have seen long QT syndrome patients that are dying in the early age of, their 20s, 30s, and sudden cardiac death, playing baby, the person dies. I think mostly because of long QT interval. I think we need to do a big study, I think, on this.
So Dinakar sir, would you like to add your thoughts on routine screening?
To tell you very frankly, I learned many things when we have done Neo Gurukul and Cloud9 we have done together cardiopulmonary venticon. That time I think so we have called even Gautam Suresh sir. I think so unfortunately he was not able to come that time. I learned all these words and I learned something in that conference only. But I don't have much experience about all these things. Only I read. But I never seen even in my babies this long QT interval because I have to tell very frankly. I learned only that word in even cardio. Kishore Kumar sir, correct? Yes or no sir?
Kishore sir,
I think so. He slept. Okay. Okay. We have done with cardiac. Okay. I don't know much about.
Would you like to add with your experience anything to this, sir? Would like to know your opinion as well, sir.
It's controversial, and there are some people who advocate for it. And I think the incidence may be 1 in 2,000 or 1 in 3,000 births in Western countries. I don't know about India. But we are not doing it in the States because the benefits of screening have not been conclusively proven. But I would still say it's something worth researching and investigating. Maybe some of the PGs or DM students can do a study on it.
I think a few more questions on relevance of PDA grading. Venkatesh sir?
Pardon?
Relevance of PDA grading. Gradient.
Yeah. I make it very simple. The relevance of, you look at the clinical phenomena, a lot of grading systems have been done, and still I think 2019 also a lot of articles have come on grading system. They have looked at only 3 important parameters: the clinical features, echocardiography, and then you got what is called the gestational age and chronological age. If you look into these things, we can do on our own grading system. If you feel that. And what grading system mainly depending on clinical plus echocardiography. I have not seen any clinical staging done only using the technology. It's basically the clinical and I think basically we need to look at most of the times what's happening here is if you look at 1970s and before, people they were diagnosing only with clinical features. Now amalgamated with technology. I think the combination of that, we need to have a local scoring system. I think a lot of books, they come with Martin and then if you see other people, they have graded a lot of systems actually, Arvind Sehgal and all. But yeah, I think there is a need when we combine these two, clinical and the echo part. Definitely, yeah.
And I think sir has one question which all of us, most of us would love to know that. Karthik sir?
Yeah, Venkatesh, nice presentation. Only thing is a final answer about PDA management. There's a lot of approach. A lot of people do targeted echo screening in babies less than, let's say, 27 weeks gestation. Then they wait for symptoms in babies to develop hemodynamically significant ductus in babies more than 28 weeks gestation. But based on all these clinical and echo findings which you are suggesting, what is the best plan of management as of today?
Best plan of management. I not talked about the management because my topic only was actually echo evidences. That's the reason I had to just.
But what would you suggest?
My suggestion is very simple because you know that whether before the symptoms appear and after the symptoms appear, that's all. We have two conditions, whether we use technology or not. In a scenario where if the baby is any baby between 26 and 30 weeks, if the baby, I know that this baby has got something before the symptoms appear, echo evidences, I keep watching this baby. If any evidence of what is called as clinical sense, for example, I look at on echo before the symptoms appear, some of the features, I keep recording that day 1, day 2. Then I keep looking at the other areas of the heart. For example, I look at the brain, I look at the other systems like gut and renal systems. If I feel those things are also compromising, so for example, a baby develops suddenly on day 2 intraventricular hemorrhage, grade 1, and there is the increase, we know that increased resistance will cause PDA, and that causes the intraventricular hemorrhage. If I see them, there's a clue that clinically that baby is showing, and also ductus, I will go into the Doppler changes. If I feel that both are convincing, then I may start. Otherwise, the best therapy is if I don't see anything correlation with these two, watchful is the best thing. We keep watching this baby every day. And always remember that it is the functional aspect of the thing. When we do echo, it is not something I do echo at that point of time and then I say that start medication. No, I look at all the features every day, sequentially.
I think that's very well put, Venkatesh, because of the current scenario where paracetamol, even orally, a lot of data suggests that it can help close. A lot of tendency is there to close a ductus just because it is seen echocardiographically to be a big in size. So I think the point is well taken. Thank you.
Thank you.
So I think we have come to an end. Would you, Dinakar sir, would you like to add anything?
Excellent.
I think they're unable to hear him. It's okay, sir.
No, it's a very good thing, Prashanth. You people are doing a great job. Good. All the best for speakers. Thank you.
Thank you. So we'll conclude the session. So we have another session coming up this Saturday. So we will be putting all the details. I would request all the participants to join us again this Saturday evening between 5 to 6:30. Dr. Pratik and Dr. Naveen Jain would be speaking on the topics which we'll be, putting across in the Facebook, and we'll be sending the all the details. So thank you very much. Thank you, Venkatesh sir, for your excellent presentation. Thank you, Prashanth, for making arrhythmias. Arrhythmias is like a tachycardia. So you have stabilized our heart and rhythmic contraction. Thank you very much. Thank you for all the seniors who have participated. Thank you.
Thank you, sir.
Thank you for all feedbacks.